Knowledge of autism spectrum disorder and ADHD is evolving and improving. And joining us now to explain how better diagnosis, treatment, and early intervention can improve outcomes for children and their families, we welcome back Dr. Peter Zatmari, Chief of the Child and Youth Mental Health Collaborative between CAMH, Sick Kids, and U of T. Let's just get these stats out there before you and I chat, which is ADHD is the most common psychiatric disorder diagnosed in children. It affects 5 to 12% of school-aged children. Approximately 8 to 10% of males and 3 to 4% of females under the age of 18 have ADHD. That according to the Canadian ADHD Resource Alliance website. Okay, let's start with ADHD. Warning signs at what age and what are they?
Well, the important signs of ADHD, which stands for Attention Deficit Hyperactivity, so that would be kids with short attention span, distractible, easily sort of their attention goes from one topic to another. They're impulsive. They do things without thinking. They're not conscious of safety issues, running across the road, jumping off the couch.
So kids are scattered all the time anyway. But this is
That's
beyond
right.
that.
This is all the time and in multiple settings. That's what makes it different from normal variation, is that it happens all the time, it's impairing, and it happens in multiple settings, like both school and home. That's the key.
Gotcha. Now let's talk autism, because as they now call it ASD, Autism Spectrum Disorder, about 1 in 68 children has been identified with autism spectrum disorder, and ASD affects more than 1% of the population. Here's something. Boys with ASD outnumber girls by as much as 4 to 1. Okay, again, when might you notice autism presenting itself in kids and how?
So there have been some really good studies done on this following the younger siblings, the baby siblings of older kids who have ASD. And because it's a genetic disorder, because it's inherited, those younger siblings are at risk. And we've been able to follow them. There's a great Canadian group led by Lonnie Zwigenbaum and Susan Bryson that have followed these kids, and they're finding that between 12 and 18 months is when the first signs of ASD begin to emerge.
And they would be what?
So, eye contact, engagement, not paying attention, clumsiness, interested in sensory stimuli, those sorts of things. So,
when you say eye contact, you mean no eye contact?
Well, it's not social eye contact. Okay. So you might look at mom when mom's not looking at you. That sort of thing. So eye contact's not really being used to negotiate a social interaction.
Boys way more than girls. Any theories on that?
Well, be careful, because that's the diagnosis rate. I think one thing we're learning is that girls don't have the same presentation as boys. And girls, there may be more girls out there to even out the sex ratio, only they're not being recognized because girls have better social skills in general than boys do. And that sort of protects them, so they're not as severe in some ways as some boys.
Now, when I was a kid, there was always a guy in your class, right?
Yeah.
You remember he was, he's got autism.
Yeah.
No one says that anymore. There is now an autism spectrum disorder.
Right.
So what does that encapsulate?
Well, what that really means is that there's no such thing as classic autism. So people used to say, oh, he doesn't have autism because he's not classic. He doesn't sit in the corner, rock, no eye contact, that sort of thing. The change here has been the recognition that there are a variety of presentations. There is a spectrum of different presentations, like the colors of the rainbow, right? It looks different at different stages. The same kid can look different at different ages, and two kids are very different, even though they share these common characteristics of difficulties in social communication and a pattern of repetitive stereotyped play. Those are the two fundamental characteristics that all kids have, but within that, all kids with ASD have, but within that there is enormous variation.
So it's more complicated nowadays, more complex nowadays, which makes me wonder, teachers, early childhood education workers, pediatricians, daycare workers, these are all people who deal with children on a regular basis. Are they all adequately trained to recognize this increasingly complicated disorder now?
So they're certainly better today than they were 10, 15, 20 years ago. And I think that accounts for a large part of the increase in the prevalence. That 1 in 68 or 1% of the population, that's because these folks have become much better at recognizing the signs of ASD and are sending kids off for evaluation and for assessment. And also, the criteria have changed. The criteria are much broader today than they were when I was training in the early 80s for what autism looks like.
So if you're a parent with, let's go back to ADHD for a second, hyperactivity,
Right.
remind me.
Attention deficit
Hyperactivity disorder, right. You suspect your kid may have it. You
Right.
take them for an evaluation.
Right.
What's a doctor going to do in that evaluation to see if he or she's got it?
So the doctor should take a very careful history from mom and dad, a developmental history, birth weight, birth trauma, birth injuries, a family history, because it is an inherited disorder. Look at the signs and symptoms. Do the signs and symptoms happen in multiple settings, both at home and at school? Get some school records, get some school reports, interact with the kid, see what the kid's attentional capacity is, how impulsive the child is, how overactive the child is, and then sort of put that together into a diagnostic formulation and see if that works.
And as we discussed in the previous debate, how do you as a clinician know now's the time for meds?
So the time for meds has more to do with impairment than it does to the symptoms. And we need to distinguish between symptoms and impairment. So there's a lot of people out there in the world that have mental health symptoms, but they're functioning really quite well. Well, they don't need treatment. And so it's when impairment comes together with the symptoms that we need to think of a treatment plan. So is the kid having difficulty concentrating at school? Marks are going down, doing unsafe things, getting into a lot of fights with other kids because of being impulsive and not being able to control their behavior, being ostracized and isolated as a result. Okay, that's signs of impairment, and now you got to start to think about instituting a treatment plan.
Do children in this province have the right to refuse medication that their parents and or doctors think is in their best interest?
So we have assent for kids and consent for kids. So after the age of 16 or so, you need consent. Under that, you need assent. So they
What does
don't,
that mean?
So that means their behavior would indicate whether they do or don't agree with taking the medication or any kind of treatment plan. Their behavior would indicate if they're fighting, struggling, if they refuse to take the medication, that's a sign of non-assent. And really, they shouldn't be forced to take the medication if they're not giving assent to doing it.
I presume, though, that let's take a 6-year-old who
Yep.
may be suffering from ADHD.
Yep.
A 6-year-old is not, well, I shouldn't say, I should ask, is a 6-year-old capable of the intellectual process of giving assent to this kind of thing?
Yes.
Really?
Yes, we should give kids the credit that they deserve, that they're actually a lot smarter than we give them credit for, and they should be part of this shared decision-making process. So this should not be a decision that comes from the doctor and is handed down. This is a shared decision-making process where the doctor might say, look, here's a treatment option. Medication is one of them. Here's the benefits of medication. Here are the risks. This should be done with the kid present, with the family present, and then everybody makes a decision together as to whether this is the way to go, or whether we're going to wait, or whether we're going to try some other things first. So it ought to be shared amongst the whole family, and the kid needs to be part of that.
In my experience, children of the age of 6 can have opinions which are very different from those of their parents or their doctors.
Right.
So what if the doc and what if mom and dad believe, yes, these meds would be very helpful to your condition?
Right.
And you as a 6-year-old say, I don't care, I'm not going to do it.
Right.
Who wins?
Well, I don't think it's a matter of who wins.
I knew you were going to say that.
It's a matter of, okay, what are the issues here? What are you worried about? What are you scared about? Let's talk about that. Is it a matter of stigma? Is it a matter of being isolated and identified? What are you worried about? Can we deal with those kinds of things? So you just need to be sensitive to the communication challenges, right? They're not going to be, kids that age aren't going to be articulate as an adolescent or a young adult would, but in their own way, they're going to be able to communicate, and the physician with the parents who know that kid best need to be able to understand what's actually going on here, and can we address the barrier and then move forward from there.
Just in our last minute, because I presume this is a bigger deal nowadays because earlier diagnosis is key to making progress on this thing, right? So if you get there faster and you get everybody on the same score sheet earlier, the kid's going to do better.
Absolutely, yeah, there's no question about that. Yeah, for sure.
Any tricks to to seeing how that happens, you know, to make sure that that happens?
I think the key to a successful implementation of a treatment plan is communication, and the communication of the evidence, and making sure that everybody knows what is the actual scientific evidence, what are the clinical practice guidelines that, you know, that professionals have come up with and that think of as sort of standard best practice, sharing that with everybody, going through their hopes and values, worries, fears, putting those on the table, and then making a joint decision, not only in the short term, but in the long term. What are we going to do over the next 6 months? How are we going to evaluate whether this is working or not working? If it's not working, what are we going to do? Well, you know, what's our plan B? That sort of thing.
Gotcha. Very helpful. Thanks so much.
You're very welcome.
Dr. Peter Zatmari, Chief of the Child and Youth Mental Health Collaborative, which is CAMH, Sick Kids, and U of T. Great to have you back here at TVO.
Thank you.
Help TVO create a better world through the power of learning. Visit supporttvo.org and make a tax-deductible donation today.